No, I don't think I did know what I was doing. When I was studying in seminary, I ended up in an emergency room. Probably the pivotal moment for me came when an elderly fellow came in full cardiac arrest. CPR was being done, somebody was ventilating, and it became clear that whatever had happened to him was simply not survivable. And we were all in the hallway just outside of this treatment area. We could see everything that was happening. It was just dramatic. There came a time, as often does, where the physician said, "We can't fix this guy, we need to call it," and somebody looks at the clock and they write down a time of death. Whereupon, one of the nurses from the treatment area went out to the waiting room where this fellow's family was. And the door was propped open and I could see that part of the interaction as well. And the nurse asked a simple question of this man's wife. How old was he? And with that simple statement, with that tense of that verb, how old was he, she knew. And she let out a scream that I remember to this day. And in that moment I said, this can be done better. So back to seminary I went, started to take some chaplaincy training, and ended up doing that work for almost a quarter of a century. It can be done better. There are lots of things about the death and dying experience that can be done better, and we've learned a lot along the way. Now it's just a matter of applying some principles that are pretty well tested.
Honoring Choices, Health and Faith in Minnesota is a TPT production. Funding for this program is provided by the Bush Foundation.
We're going to want to think together before these modules come to a close about how you as a church community can serve those who are experiencing this time of their lives.
Healing is possible even when cure is not possible.
Expire is one you hear in the hospital a lot, like it's a library book.
Our job is to begin a conversation about death.
Barriers to starting the conversation and some strategies for overcoming these barriers.
Honoring Choices Minnesota is an initiative of the Medical Society to change the culture related to end-of-life care planning. That's a big issue.
Yeah, I've experienced that.
Now, would you say that made it easier on the family when the time came?
Right. You knew what to do. I mean, everything was in order. She had everything to the detail written out.
There's a lot more to this issue of end-of-life care planning than just medical. Faith is a very big deal in this issue.
Churches are already pretty good at this. My guess is that your church is good at this. There are certain things that just kick into gear.
You're cared for at the beginning of life. At the beginning, your parents decide where you're going to go to school, what shoes you're going to wear. As you grow older, you might decide where you're going to college. All through life, people make decisions and people make plans, and it's part of the process. And then we get to the end of life, and people are like, I'm not going to decide anything right now, because they don't want to think about it.
You don't have to put somebody else on the spot about it.
We then began to explore, well, if we're to partner with the Council of Churches, how does this fit in with the larger Honoring Choices initiative?
For any journey, you make preparation.
That's what I was just about to check. Did everyone?
You make preparation for work. You make preparation for marriage. You make preparation to go on vacation. We're always making preparation.
Minnesota Council of Churches is a membership organization, mostly mainline denominations. We represent more than 2,000 congregations and about 1 million Christians.
I'm going to share a scenario where I had to have a difficult conversation.
We invited in a number of people who had background in teaching or healthcare.
Several retired clergy. We had seminary students. We had a psychotherapist in the group.
Fear is a very common barrier to having these kinds of discussions with family members.
All volunteers who wanted to come help us get the word out about the importance of making decisions around end of life.
So that they could make my decisions for me, so I'm not making decisions related to my health based off of, like my emotions at the time, as opposed to what I really would want, what I actually want when I'm healthy, like now.
As facilitators, if you're helping someone fill these out, that would be a question to ask them, just so they have a clear understanding. You have a clear understanding. It's weird. Even though he was bald from the chemo and everything, I remember walking through, he was sitting in the living room in the chair and looking at my husband thinking, I've never loved him more. And I still get emotional. It's almost been 10 years, but you know, it does. It changes your life when you're faced with life and death issues.
Handle that stress, and that's okay. We're all human and we all handle things differently.
They are the first group of students in central Minnesota to achieve the certification.
I want the options now to...
It's a national certification. It doesn't really matter who decides they want to receive this certification. If they go through the curriculum successfully, they will receive that certification and will have those skills.
Well, I'm Catholic, so I think it would be important to have last rites included.
It became clear that we had a really unique opportunity.
I mean, this hasn't crossed our mind.
We identified test communities. Is the smaller community more apt to take on this issue because it's a smaller knit community? What are the differences when you take this issue into a major metropolitan area?
It represents diversity, and we can't do without each other.
There's a lot more churches, first off. Secondly, they're not as tied to one healthcare system. And whereas in smaller communities, like in the rural settings or even in the mid-sized communities, they might very well be tied to one system. We train ambassadors that would actually go in and give presentations in their congregations.
The most expensive week of your life will be the last week of your life.
We're great at funerals. Churches really know how to celebrate a life with the help of your pastor.
Let us pray together. God, from whom all life flows in its rich diversity, you call your church as the body of Christ to be united in love. May we continue our unity in diversity and strive to work together to live, to witness, and to build up the kingdom of your abundant love to all.
We are a culture in the United States that do not like to talk about death because we don't want to get old and we want to live. And we have to do lots of things to be young and to look young and to be youthful, and that's okay.
And we all have a sermon, a witness to the world.
When I was 16, I drove family cars for a funeral home. So I was around death then, because in the South, people have family cars. A family car is just a car that you would rent, that people would say to the funeral home, we want cars driven like a limousine or a town car. And it's so prevalent that when my mother died, my sister, who lives in South Carolina, she was making a list of 3 cars and who would sit where and who would sit by each other. That's tradition, and that's a ritual for some cultures as it relates to death and dying. How many times have someone died and we did not know they were sick? I don't want to be a burden means I can't do what I used to do. I might not be able to walk. You may need to give me medication every 3 hours. I don't feel like a productive person anymore, and I need care. And I don't want to put this on my family. I just want to go. I don't want to be a burden. My husband said that. My husband died 2.5 years ago. 3 months before he died, we opened our home up to people that if they wanted to come and sit with us and have a meal with us, they could do that. If they wanted to have private conversations with him, they could. We talked about it. We weren't afraid to say he was dying. We were very realistic. We knew he had a very rare cancer, and we knew many people didn't survive. But we still had hope.
Backgrounds and different places that we have come from.
That was the hardest thing I've had to do in my life, because I was the leader of this church, and you still need to be the leader. But also my husband was dying.
And so you'll hear some things about people.
We don't have language to talk about death. And I think when we can help people talk about dying well, that's important. To me, that's important. so people don't feel so alone? How can we talk about death where people don't feel so afraid? Up until about 10 to 15 years ago, African Americans did not cremate. They wanted the body to be at the funeral and thought that if you had a cremation 9 times out of 10, you were poor. You just didn't have the money. And that has really changed now. We're having more memorial services than funerals. Some people just have a gravesite prayer. Some people don't do anything with their loved ones now.
In the Iron Range, death was highly ritualized here. With our strong Catholic element, Orthodox element, you ritualized a person's death as a way of grieving and saying goodbye. More and more people that are simply not ritualizing the passing of a loved one. I think there's at least 4 or 5 reasons for it. One is death denial. Another is simply the fact that we now have more cremations, which make it easier for us to delay a service or put it off entirely. The economics of the death industry or funeral industry, it's just very expensive. The breakdown of family dynamics. Many families simply are not functioning with the closeness that they had 10, 20, or 30 years ago. And so consequently, when, Grandma dies or Uncle Joe dies, we're going to be able to get enough people back together to have a service, and should we have a service? A final issue, the church and the lack of association with religious institutions of faith today. All of those things are happening. They have coalesced here in a way that I would not have expected. Because 30 years ago, you never had a death that wasn't ritualized. We spent an awful lot of money on that last week. Should we be doing that? Ethically, should we be doing that? Is it something, if you had a choice, you would want to do? What would you want for your family? Virtually everybody that I've talked to about end-of-life issues has said, yeah, that's something that we really need to do. Does it make us uncomfortable sometimes to talk about them? Yes. But I think there's a general awareness. This is probably a good thing. How do I go about doing this with my son or daughter or with my spouse? Or how do I get Grandma to talk to me about what she wants? Who's going to speak for me when I can no longer speak for myself? We're going to do something right now. You have a little set of cards in front of you that's called Go Wish cards. There are 32 cards in this deck. I want you to turn them over. What would be of most value to you? There isn't just one value. Some obviously are not as important as others. Anyone that works in religious or spiritual care ultimately gets confronted with end-of-life issues.
So many of the patients and families that we're providing care to, they know people that work here. We may know them, I may know them, the nurse who provides care may know them, or know someone within their family. As a smaller rural hospital, our financial challenges are great, and so it's been difficult for us to be able to have the financial ability to have a paid chaplain program. We have a number of local clergy members who, besides their own churches, are volunteering and are serving as a chaplain here in our hospital. Chaplains have special training to really meet people where they're at spiritually, whatever faith they're at, or if they have no faith.
40 years of ministry, I cannot tell you the number of times in which I have been asked by a family member, what do you think Dad would want us to do? The situation is grave. God forbid somebody gets in a car crash at any age, unable to speak for themselves. What would they want?
We have patients that have everything from Alzheimer's, cancers, heart failure, respiratory failure, neurological disorders. We have some families that come in that have everything written out. Everything they would ever want is all written out. They have very open communication. Then we always have the opposite end of the spectrum, which are the families who they don't want to talk about it. They don't want to look at that. They don't want to deal with that.
Hibbing has about 16,000 residents, something like that. It has lost about 2% a year for a number of years now. Schools obviously have lost population as well. It's a very beautiful area. The people that are here work hard and play hard. We have one of the highest alcoholism rates in the state of Minnesota. We have one of the highest suicide rates in the nation.
Ritualizing isn't important anymore. Some families don't have services at all. We used to assume that everybody was connected with a church. The natural question was, well, which church or pastor or priest should we call? And now many times the family sits down and says, first thing, we don't want a pastor or a priest.
I came into the service in 1983. Cremation rate was about 3%. Right now we're standing at around 60 to 65%. People are spending less time together. So why are we going to gather for that? The fact that everybody's economically stressed, that they're trying to save money. The third issue is it's just easier. I don't have to deal with my feelings if we don't have anything.
Where we die, upwards of 80% prefer to die at home. Why do you want to die at home? Grieving is a very human response to loss. You can deny it. You can say, I'm not going to have those feelings. Now, there are some people that really do not prefer to die at home because they know there's no one at home to care for them. But everybody goes through those feelings and deals with them one way or another. The ritualized funeral service is our way of doing that, as every culture has had it. There's no culture that hasn't had a ritualized funeral service.
The earliest that I really remember was my grandmother, and I was in 2nd grade. It was my father's mother, and just remember the sadness around that. It was at Christmas time, and that stands out to me.
My earliest remembrance of death is my grandmother as well. My mother wasn't always very emotional in that way, and just remembering her being very sad and crying and just being...
I've been assigned to the area of the northwest suburbs, Coon Rapids, Anoka, Elk River, and since it's also the area where Mercy Hospital is, it's a great connect for me. Primarily, I work in the intensive care unit, ICU. My work is working with the most critical patients and working with the families because the patients usually are not able to speak for themselves. Sometimes there's a diagnosis that's been given to a patient that's very critical or very threatening that may mean that they have a certain amount of time to live. In many cases, the family has to look at what are the goals and what are the options. So as chaplain, I'm more instrumental in saying, what would your loved one want? I can think of many people I've talked with in ICU, and do you know what your loved one's wishes? Well, I think so. Or my wife knows what I want, or my husband knows what I want, but it's never been verbalized. I think it's great when the medical side and the faith piece or social work or all those pieces can come together.
Most recent deaths, so have you experienced
We learn from each other.
If I can't wash myself, if I need diapers, let me go. I mean, you know, everybody's got different standards.
Well, I hope you don't serve the spaghetti hot dish at my funeral.
There's a phenomenon called compassion fatigue. It surfaces amongst caregivers at varying times. What I've found to be the antidote for that is the ability to tell your story to a caring individual who understands what you do for a living. I was so committed to doing that I would just do it anywhere. When somebody would ask me how I was, I would tell them the truth. And this included the checkout lady at the grocery store. Hi, how are you? Well, you know, I had a kind of a tough day today. I was a part of the 3 or 4 deaths in the hospital. My kids are sick. I can't find a decent grapefruit. Whatever the thing is, I'll just, you know, and some people will be sensitive, and other people will just go, well, milk $1.89, lettuce, you know, 69 cents, and they're just not programmed to hear anything other than fine. Telling survivors about death is difficult. So communicating bad news was something I had to do almost every day. It's never easy, but if it's done compassionately, then you can walk away from it. Hopefully both the family members and the provider feeling like it was as good as it could have been.
The gift of congregations is that we are resource rich.
Bethesda Lutheran Communities has resources for people with intellectual and developmental disabilities, and they wanted to cover something on grief and loss. There hasn't been much directed for persons with intellectual and developmental disabilities. What I thought was important was to talk about the funeral. It's the celebration of the person's life, and it's a time that we support one another. It's a time where we share stories and emotions, and some of this stuff lingers. I wanted to deal with the reality of loss on this side. We've missed that person, and it's okay to be sad. It's okay to have these emotions and still have faith.
Illness, I would try to fight it.
Try to fight his illness?
Oh yeah, you would never be able to be in places like this. Right. And I kind of want to be around to see what the future is going to be like.
Also in there, I designed a trip to a funeral home where the students would go to a funeral home and see where the caskets are, and to have the funeral home director talk about what happens when a person dies and before the funeral. Sometimes, especially with the intellectual disabilities, the people around them think they're doing the best and trying to protect them and not talking about it. But I find it's the opposite. You need to talk about it.
I just love working with bereavement. In the consult, we go in and talk to a family who's just probably received some pretty serious medical condition information, and they may or may not have expected that. And so the doctor comes in, the nurse comes in, the social worker comes in, and the chaplain, so that we look at just not the medical part of a person, but the whole person. What I talk to a lot of people about is hope. Something like 86% want to die at home, and if they're here in the hospital and they're dying, then our job is to get them home, so we're fulfilling a dream for them.
When people come into a hospital with an illness, the presumption is that they want any treatment that will extend their life. And so they start down the road of being treated and receiving aggressive treatments. If they don't put up a sign to say that they don't want these things, or maybe it's gone too far, then it'll just keep going. And what we end up doing is prolonging people's deaths rather than helping them live a longer life. One thing I would say to people entering the medical field is that if somebody tries to tell you to separate your emotions and your spiritual side from the work that you're doing, that's probably bad advice. When I went through training, we did not think about the spiritual side of anything. We were not to be emotionally connected to our patients. And I found that that was a real disservice to patients.
I learned about advanced care directives in my late 20s. And it was through a parish nurse that was speaking during a Bible study. And my husband and I thought, hey, we're healthy, why not? We have small children. And so we filled out our healthcare directive. When my husband turned 39, he contracted stage 4 cancer. And even when we were in the hospital and it was clear he was on a downward slide, we did it again. And so it's important to not just do it once, put it away, put it in your safe deposit box where nobody sees it. You need to have that document accessible. We had had our conversation, so I knew what his wishes were, and I had peace. And I knew when it was time then to let him go, when enough was enough. And so in that situation, it was a beautiful death, you know.
All of us come from different walks of life.
Working with my colleagues, my original thought was that I would try to bring this just simply into the nursing program and work with my students and hopefully could find a way to get this into the curriculum that I teach. I thought, well, I really need to start approaching some of my colleagues and see, first of all, if there's even interest in designing a curriculum or a course for students where we could have students from multiple majors be involved. And not only did I get no resistance, I got tremendous support for it. And so I'm working with colleagues to design an elective course. I have support from the chairs of the departments in the School of Health and Human Services and from the dean.
It's just inconceivable, this thought that someone who was there yesterday might be gone today. A lot of deaths happen that way. You just don't see it coming. So being gentle with people at that time of amazing transition. We were fine this morning, tonight our world has changed. Everything is fine, and then it's just not fine, and probably will never be fine again. To handle people gently at that moment is really important. What's coming next? I don't know. I tell my wife, I tell God, surprise me. I can't wait. I'd like to wait a little while, but as for what comes next, I don't know. That's not my job. I'm sales. That's management. I hope it's just great.
Honoring Choices, Health and Faith in Minnesota is a TPT production. Funding for this program is provided by the Bush Foundation.